My ears are wide open. When it comes to TXA, let's say you're talking to that young medic who is going to be alone and afraid. What would you recommend when it comes to TXA? Like, do I hit him first with TXA? Like, that's another situation is guys are like preloading like 20 ml syringes of TXA if they have the supply to backfill that, because it's not going to last that long in there. But and they'll get their IV and they'll use the TXA to just flush it versus using like a saline or whatever, and then connect their blood and then start resuscitation. So, is that recommended? Don't do that. Do that. That's awesome. Like, there's always a bunch of confusion. So just your opinion. How soon should I be using this TXA? And like, what is the right person for this?
Yeah, and I think, and I'm just going to generalize it for the pre-hospital setting in general to kind of talk with civilian side and military side. I think preloading TXA is an exceptional idea, and it's a good preparation, because the one thing we don't want with TXA in basically any type of other pre-hospital intervention is to delay that transport to the next level of care, right? We know that if we can get patients to a surgeon or a trauma center or whatever you are in the military, at least a team outside of yourself, we can improve care and outcomes with that kind, and also offload you so you don't have to take care of so many other people too. So anytime, I think if I'm not sure what the pre-hospital providers in the civilian side do, if they're allowed to preload, that's outside my knowledge. But I think preloading it and running it in and giving it as 2 grams right up front, right as you have a new trauma patient, I think that's very fair. If your organization, I wouldn't use John's recommendation, as I would look at your organization and what that recommendation. The military, I know it's 2 grams. That's easy. Everybody has to do that. And for the paramedics and the EMTs out there, I would look at what your organization, what they recommend, obviously, and get back, because you don't want to go outside the standard of care for whatever you set as your protocol.
Nope, definitely wise advice. Any other thoughts or any other kind of myths out there with TXA?
No, I think TXA, we talk about all these things. I don't think I have the years yet to really see the ebb and flow of a lot of these, hemorrhage medications that we have. It has been one that's really stuck around for a long time for many purposes, because it does show, it's really shown and it's solidified as a medication that shows effectiveness if given within 3 hours of bleeding. You kind of briefly mentioned what happens if you give it after 3 hours, right? Really, the two big things are it's not as effective. The multiple studies have shown that if you give it after 3 hours, you're not really getting the benefit of that medication. And then there's risk of TXA start to come into play. Like, should we be giving this medication? Do those risks now outweigh the benefits? And then secondly, there are actually some studies that that TXA given after 3 hours might have increased bleeding. That is, and that's that's kind of hard to say, and that's a suggestion, not like a proven fact. We'll study a medication that may increase hemorrhage, but the final word on it really is that you see factor 7 PCC, 4-factor PCC, and 3-factor PCC come into play, and all these new things that pop up. The TXA has really kind of solidified itself, a trauma drug.